Hi, Dr. Filippo.
Hi,
Hi. Thank you for being here. Welcome to our conference.
thanks for
Can you
having
tell,
me.
uh, anytime, anytime annually. Uh, can you tell us what kind of doctor you are and where you practice?
Yeah, so I am a urologic oncology fellow and a clinical instructor at the University of Washington in Seattle, Washington.
So does that mean as a fellow you see patients or you teach or what?
Yeah, so both. So I finished urology residency, and then to get extra specialization in oncology and urologic oncology, I'm doing extra 2 years of training essentially. So as a clinical instructor, I see my own patients and I do my own surgeries and I work with residents and other members at University of Washington.
So just as a sidebar, it sort of raises an interesting thing. At the end of all of this, all of your training, between from the day you got your BA till the day you sort of stop officially training, how many
hmm
years would that be?
So that would be, we'll have to do the math together. 4 years of
Okay,
college, four
okay,
years of
okay,
medical school.
okay. You
So
can
that's
see my
eight.
calculator.
Yeah.
Yeah. Okay,
5 years of urology residency. So
13.
we're at 13
Yeah.
and 2 years of fellowship. So
Fif-
15.
So that's pretty good.
So yeah, it's a pretty good amount of training.
Yeah. Okay. So yeah, I mean, people should feel confident that their doctor studied something during, some time in med school. It's not just med school, it's like lots of stuff, especially
Yeah.
when you specialize. Uh, we're going to talk tonight about pain and misery and what a field called palliative care. Now, so I mean, we'll start with like the largest misconception that patients come into our support group network about palliative care versus hospice care. Can you sort of guide us through that, please?
Yeah, absolutely. So, just to start, palliative care is a special kind of field of medicine or medical care that really hopes to bring the best quality of life to patients. So, it is usually a team of many, many individuals, doctors, nurses, chaplains, social workers, and really all with the goal of helping people live with a serious illness. So that is any serious illness that can include cancer, it can include heart failure, it can include, a number of illnesses where patients are having to kind of deal with medical care for it for quite some time. And palliative care really just focuses on helping patients provide relief from symptoms from that serious illness. So it's something that can be given alongside curative treatments for illnesses. It's not necessarily something that you have to give up care on in order to receive. And that's one of the main ways that hospice and palliative care are different. In hospice, which is usually reserved for patients in the last 6 months of their life, you actually have to forego medical treatment for an illness in order to be able to receive hospice services. And palliative care is appropriate for anyone at any stage of their serious illness. And you do not need to forego the curative treatments that you would want to pursue in order to see a palliative care physician or get their services. So they're
So
really two different things.
they are, but it sort of raises the question, and many in the thousand virtual people sitting behind me. I mean, if if hospice care takes treatment possibilities off the table, why not just everyone opt in for palliative care?
Yeah, and it's a great question. Palliative care is a service that unfortunately has a lot of misconceptions around them. So, when you ask patients, what do you think of when you hear the word palliative care, a lot of them say death. And a lot of them think of the end of life. And, a lot of patients undergoing curative treatment, especially for prostate cancer, just aren't there yet and think that, one means not being able to treat the other. So, anyone with a serious illness can seek out and be helped by palliative care. Um,
So, yeah.
mhm.
but it doesn't sort of get to the grain of the question in a sense like, I'm in pain. I am
Mhm.
in, I mean, I'm not, but I mean, I'm pretending to be in pain. I'm pretending to be an advanced stage prostate cancer patient.
Mhm.
I may, in fact, be nearing the end of my life,
Mhm.
but, I don't quite want to, take my chances off the table.
Of course.
Why not just do palliative care instead of a hospice where I have to sign something that says no more treatment?
Yeah, and that would be completely reasonable. I would, if you were my patient and told me, that you were experiencing pain and you wanted some support in going through this illness and the treatments that have to do with advanced prostate cancer, I would immediately refer you to a palliative care physician.
Yeah. So, and yeah, that's reasonable. Uh, and forgive me, but there's a mosquito flying away. It's around me. It's sort of like Mike Pence's fly, but I have a
Yeah.
mosquito. So hopefully
I
we'll
hope it doesn't land
just,
on you.
it did, but the slap didn't get it away. I'm trying to avoid mosquito pain, but not to
Yeah.
minimize the idea of pain. What's the difference between mosquito pain and the kind of pain that sort of navigates somebody into a palliative care kind of setting?
Yeah. So the way I talk to my patients about it is if that pain is really affecting their quality of life on a day to day basis. So, it's something that they are thinking about a lot more than they used to, or it's something that's causing them or their family or friends that are taking care of them or helping to take care of them, if it's causing them distress in any way. Or if it's something that's getting worse and is expected to get worse kind of throughout the course of the illness. I think palliative care is really good at helping kind of manage that pain when it's affecting quality of life like that.
So do you have to like test the patient out to see if they achieve that pain threshold for palliative
No,
care? No.
not at all. It's a completely patient directed decision. It's not something like a diagnosis where they have to check certain boxes and get certain tests in order to qualify. It's a consultation for an additional medical or advanced care provider as opposed to having to meet certain criteria.
Yeah. And when we think of pain, when we patients think of pain, we don't
Hmm.
think of it as a specialty necessarily. In fact, it's sort of like, why isn't my regular urologist taking, or radiation oncologist or oncologist,
Hmm.
why aren't they taking care of my pain? Why do I have
Yeah.
to see someone else?
Yeah, and it's true. A lot of urologists and radiation oncologists are able to manage chronic pain that results from cancer treatment, but this is just kind of an extra layer of support. So when things have been tried and it's either not working or the patient is just feeling a little bit of just wants an extra layer of help. This palliative care service team can often help with that and many other things associated with serious illness.
And is palliative care refers strictly to pain, or nauseas included, dizziness, things like that?
Yeah, so it's any symptom associated with a serious illness. So that can include the things you mentioned, so nausea, pain. It can also include a lot of the psychological burden that comes along with illness. So stress, anxiety, depression, all of those things are managed well by a palliative care physician. And then on top of that, they can help with kind of the logistics or the navigating the medical field in a way that is a little bit easier. They can help with planning in terms of, making sure that patients are able to talk to their families and friends about what they want for themselves as their care in this illness continues. So they really do a lot more than just help manage pain.
Is it fair to say that a palliative care specialist who works outside of the hospital has a different kind of practice than within the hospital regarding vis-a-vis like stress, anxiety, quality of the daily activities of life, which are not as well managed outside of a hospital setting as they are within, things like that?
Yeah, absolutely. So palliative care is practiced both inpatient in a hospital setting and outpatient. So in an inpatient setting, it's usually in the form of consultations. So a medical team who, either the patient wants some extra support or needs some help themselves, kind of helping the patient manage their hospitalization, can consult a palliative care physician where it's available. There's also in hospitals kind of palliative care units, which kind of act more as a crisis management kind of team to help patients transition to different phases of their illness, sometimes helping get a patient to hospice if that's a transition that they want to make. So that's mostly inpatient. And then outpatient is more of a clinical setting that you would expect going to see, an outpatient doctor. So patients are able to get more of a longitudinal kind of long-term relationship with their palliative care provider and kind of map out the illness that they're experiencing together.
Right. And engaging a palliative care provider doesn't mean that you're giving up your urologist, right?
Exactly, not at all. Often the urologist and the palliative care doctor will kind of communicate and make sure, everyone is on the same page about this patient. And it's, like I mentioned, just an extra kind of boost to help patients get through what can be, a very difficult long road sometimes.
Would you, as a urologist, ever have negative feelings towards a patient who wants a palliative care specialist?
So that is a great question. I would not, but I do think that there is still a misconception in even the medical field about palliative care and its role. So I've had patients that have, maybe brought up palliative care to their surgeon or their doctor and have gotten the response of, oh, you're not there yet. You're not, we don't need to go there yet. We've got options for you. And that's really, like I mentioned, a misconception, in that you don't have to give up anything to be able to see a palliative care specialist. So I would love it if my patients asked for it, but some of them do have to be in the role of being willing to ask for what they need and sticking to it and getting it, unfortunately, because there are some misconceptions.
Is it difficult for a has it ever been difficult for you to bring up palliative care with the patient who never thought of the opportunity?
Yeah, absolutely. Absolutely.
What
Mainly
was that?
because of what I was mentioning, because, a lot of people think death or end of life or giving up when they think of palliative care. And it's really about a kind of a discussion where you can work together to kind of shift the thinking, and educating people about what it is and what it can help with. And once that happens, there's always an initial kind of anxiety in someone who has those feelings and does not want to think about it yet. But once a discussion happens and we have a relationship, it tends to go, much better. And even still, some patients are like, I don't need that, and that's totally fine as well.
Yeah. Do you find, like, for those patients who have spouses and partners and show up in your office with that spouse or partner,
Mm-hmm.
or even a child, one of their adult children, perhaps, or somebody else, do you have a sense that it's less likely for somebody to show up as a couple and describe a need for palliative care versus guys who show up alone into your office?
Um, that's a great question. I've seen both. I think when they show up as a couple, uh, I've seen both. It's hard to say. So I would more so even recommend palliative care to someone who doesn't have that support system, because going through cancer, serious illness is really taxing, just mentally and physically, and not having the support system of a church community or a significant other or a family can really make it difficult and have a patient really experience a lot of the symptoms of that illness more severely. So I tend to think of it sooner for a patient when they come alone and tell me that they don't really have a support system. But I've had patients in, couple marriages or with siblings that also I think would benefit from palliative care, and bring up those conversations to them as well.
Yeah. By the way, we've been using the word palliative care. I mean, it sounds almost ghost-like as a,
Yeah.
I mean, what does it actually mean?
Yeah. So it's medical care for people living with serious illness.
And
It's
how,
very broad.
yeah, yeah, okay. And there's no better word, there's no alternative to calling it palliative care, is that right?
Yeah, not now, but it's interesting because of some of the misconceptions that I've mentioned. They've done studies to see if we just call palliative care something different, do patients tend to accept it more? And they actually do. I think because of all of this, kind of not necessarily stigma, but misconception about what it is.
Mhm.
Calling it something different does actually make patients think that they might help them a little bit more. But as a community, we are kind of sticking to it and just hoping that discussions like this can help change what people think.
Yeah, in our mail care system, we noticed like sort of a toxic effect of the semiotics
Mhm.
of palliative care. Just, it just rolls badly off the tongue. So we came up with the term misery management, you know.
Oh, interesting.
Yeah, and it actually comes from a British video called Misery Bear. That's probably on YouTube from several years ago. It's very funny,
I'll
but
have to check it out.
yeah, but when you use the right, this sort of easier and very more clearer term, of misery management, it resonates with our support group members, and then they're able to engage it, and get
Yeah.
it. Yeah, let's spend 5 minutes or so talking about what kinds of pain there are, or what kind of miseries there are in prostate cancer and what generates them.
Yeah. So, there's kind of the whole gamut. So, when you have someone, say, with low risk prostate cancer, and they're on, active surveillance where their urologist is kind of monitoring the cancer to make sure it doesn't get worse, but doesn't necessarily think it needs to be treated right now. There have been studies that have shown that patients, even with this very low risk cancer, experience quite a bit of anxiety, can experience depression surrounding that diagnosis. And it's something that sometimes makes them kind of change course in regarding what their treatment options are. So, you've got that misery. If you are someone who has localized prostate cancer and you've undergone either surgery or radiation to cure the prostate cancer, and, there's side effects from those treatments, obviously. And so men with localized prostate cancer that have treatments have the misery of, maybe urinary incontinence after surgery, or leakage of urine, erectile dysfunction, having problems urinating in the sense that they have blood in their urine, or it's frequent, or, whole host of urinary complaints. And then you've got patients with, advanced prostate cancer, where the cancer has either come back after it's been treated or spread to other parts of their body. And some of the miseries, which are significant there, include a lot of fatigue, so tiredness, bone pain, anxiety, depression surrounding kind of what the state of their cancer is and where it's going. And, kind of drowsiness and not being able to sleep well. I mean, it can be kind of run the whole gamut, once the cancer gets a bit more advanced.
Yeah, but important to notice it's a gamut. It's
Mhm.
not just about pain. It's
Mhm.
genuinely when you're feeling miserable in an somewhat, chronic way. You
Yeah.
know, I mean, everyone's going to have a pain here or there. But that also actually raises the idea of when, how do you parse out the different kinds of bone pain? How do you parse out the sources of anxiety? Or, particularly in the last 8 months or so, I mean, there are
Yeah.
opportunities for elevated stress nonstop, and probably continuing through 2021. The Is that part of the special skill set that a palliative care doctor, or as I'm glad to hear you use the word misery more frequently, as a misery management specialist,
Mhm.
is that part of what you guys know how to do.
Yeah, absolutely. And really, at the end of the day, whether or not, the election or the prostate cancer or something else entirely is causing these symptoms, there's still something that's affecting the quality of someone's life and can be made better by kind of this multimodal management that palliative care or misery management physicians, do all day, every day, and can really help bring some other things to the table that the medical team just may not have considered because they don't deal with it as often.
Yeah, and you touched on something really worth just sort of doing a push on. The idea
Mm-hmm.
is that no matter what a prostate cancer patient is experiencing, it doesn't necessarily have to relate to prostate cancer in order for you to want to fix it or
Exactly.
restore it or change it or improve it. You know,
Exactly.
I mean, everything you do as a urologist, everything radiation oncologists and oncologists do may seem directed towards the prostate cancer within a man's body. And
Mm-hmm.
there are doctors who are entirely focused on that. And, it's, I mean, that's how it is. But for most doctors, it's hopefully most doctors, the experience patients have is like, I care about you. Is that bothering you? Let me see what I can do to help you. And if not, I've got somebody in my in my phone contact list. I was about to say Rolodex, but damn, I don't want to date myself at all.
Yeah.
The idea of, so there's a whole constellation of professionals with PhDs, MDs, LCSWs, who are, the whole raison d'etre for spending 15 years in school or
Mm,
less, but is to help, because we get up in the morning wanting to make other people feel good because that makes us
right.
feel good, you know. So
And you really touched on something like prostate cancer or any cancer or illness is just one part of what a person brings to the clinic office, right? And that's seeped in values and relationships they have with their family and what they want for their life and their past, what experiences they've had in the past that change how they see the life now that they're living. And I mean, that is a part of a bigger person that really, at least my goal when I see my patients is to just really know who they are, whether or not they have cancer, and how this is affecting their life and how we can make their life as much they want, has as good of a quality and as good of a life as they want.
yeah, and eventually the goal is that you no longer need somebody who's a misery management or palliative care specialist.
Absolutely. Yeah.
Yeah, yeah. Great. Is there anything else that you've seen in your practice that we haven't talked about? That patients, quirky or otherwise, may present around this.
Yeah. I mean, patients bring so much to the table. It's hard to think of just one, but I think a good place to start is some resources. So, some patients don't know quite when to start thinking about misery management. Is that something that I need now? Can I wait? Do I need it later? And I think just harping back to what we talked about, that, palliative care or misery management is really something to think about when any symptom or any part of your illness is preventing you from having a good quality of life, and the help that you've gotten from your physicians in the form of medications or other support just isn't cutting it, and it's still something that's bothering you. Something else that palliative care can be really helpful with is helping manage situations in which maybe your view of what you want for yourself doesn't maybe agree with your spouse or your daughter or son, and what they want for you, and that having those conversations can be really difficult. But misery management kind of coach can almost help you have those conversations and get to a place where everyone is on the same page about what you want for yourself. So that's another way that they're helpful that I've seen used really effectively.
Yeah. No, it's a wonderful, you know, it's a field that strikes to the heart of why anyone would see a doctor. You know,
Yeah.
it's
And why we went into doctoring in the first place.
yeah. Right. Uh, Thank you for this wonderful conversation. Thank you for being part of our conference. Thank you for taking care of your patients and bringing them out of misery as much as you both can arrange. And welcome to our
Thank you
conference.
so much for having me. This was wonderful.
Right.